download this guy. Okay.
No, it's okay. I can read it.
Oh
You
yeah.
have because you're the host. You have to do many things. So let me do that easy thing.
Good.
Okay. A one. Can I read it?
Yes, just go ahead.
Yeah. A 1 month old infant is brought to the physician for a well child examination. His mother reports that she she's He previously breastfed her son every 2 hours for 15 minutes, but is now feeding him every 4 hours for 40 minutes. She says that the infant sweats a lot and uncomfortable during feeds. He has 6 wet diapers and 2 stools daily. He
Mm.
was born at 36 weeks gestation. He currently weighs 3,500 and is 52 centimeters in length. He is awake and alert. His temperature is 37.1 degrees Celsius. Pulse
Mm.
is 170 per minute, beat per minute. Respirations are 55 per minute, and blood pressure is 18 over 60, 80 over 60. Yeah. Pulse oximetry on room air shows an oxygen saturation of 99%. Cardiopulmonary examination shows a 4 out of 6 continuous murmur along the upper left sternal border. After confirming the diagnosis via echocardiography, which of the following is the most appropriate next step in the management of this patient? A. Reassurance and follow-up. B. Prostaglandin E1 infusion. C. Percutaneous surgery. D. Digoxin and furosemide. E. Endomethacin infusion. F. X-ray of the chest.
Sure. Okay. Thank
A.
you.
Yeah.
Thank. So first we will kind of find out some new words here and explain more before we analyze this case. Do you have any new words you want to know more?
No. No.
Okay.
Yeah.
Very good. You, yeah. So so do you think that this patient have some abnormalities?
Uh, well, the abnormalities
Mm.
is about the heart murmur again. And okay, besides
So
it,
first, we're going to talk about the history of this patient. Uh, did did he or she what? Did
uh,
did he have any did he have any abnormal with his history?
oh,
1 month old infant. We care about the history of pregnancy, right? We care about the history of nutrition, right? We care about the history of vaccination, right? Yeah. So
uh,
do you see
uh,
any abnormality in his history?
well, I think the first is the mm,
About the pregnancy? Any
yeah.
any
Uh,
abnormality?
he was born at 36 weeks. It's
Ex-
earlier than normal. Uh,
Exactly. It is premature.
yeah,
Premature. Yeah, premature infant, right?
yeah.
Mm-hmm.
But
So
okay,
anything else?
and I I can notice that the I mean the nutrition,
Yeah.
the way he's nurtured,
Yeah.
um, 4 hours for 40 minutes. So. It's too long. I mean, 40 minutes per 40 minutes is time is
Yeah,
too.
it's kind of poor feeding, right? This
Yep.
this might have poor feed the symptom of poor feeding because it have lengthened the times of each meal. Yeah. So
Uh,
mhm. Anything else?
um,
The
yes,
history of development. Any abnormality about the history of development? The weight and the leg.
yep. The weight is
Is it normal?
three. Yep, yep. The I think that is a bit abnormal here because okay, I don't know how to express my idea.
1 month old infant weighs
Yeah.
3.5 kilogram. I think that's
Wait.
yeah, it's normal, right?
Oh,
It's normal.
oh,
Okay, 3.5 kilogram with 1 month old infant. Yeah,
yeah.
we often see we often see the infant. Yeah. Oh. Mm-hmm.
How
Mm,
how how the age the weight when he delivery? We don't know that.
We don't know. Yeah, but with
yeah, yeah.
1 month old infant, 3.5 kilogram is still in the normal range. From the it's
Mm,
from the zero SD to positive to SD.
mm,
It's on the normal range. Okay.
Yeah.
Mm-hmm. And the legs is also normal. Legs. I just check it. You don't have to worry about this information because we always have some parameter to check for this information. Okay. So
Yeah.
I have checked it, and the weight and the leg is still in the normal range.
Hmm.
Mm-hmm.
Yeah.
So in the history of this infant, we noticed that there is two abnormality. The first thing is the premature infant, right? And the second thing is the poor feeding.
Hmm.
So now we will move to the clinical symptom. Do you notice any abnormality in the clinical symptoms of this trial?
Yeah. The infants rest a lot and uncomfortable during this. Um,
Uncomfortable. Yeah, during feed.
yeah.
Yeah, it's
And
yeah. Anything else?
I think he has 6 watt diapers and 2 spoon daily. It's not normal, right? It's normal.
The wet diapers actually is too little. It's too
So,
fewer than
oh,
uh, other child in this age because with 1 month old infant they often have pee 19 to 20 times per day. 19 to 20 times per day.
oh,
It means that his mother have to use more diaper, not just 6 diapers per day. It's kind of fewer than normal. Okay, and 2 stools daily is normal.
yeah,
So it means that it increase the urine. This patient have the symptom of decrease the urine.
mm.
Mhm. Anything else
mm,
about the vital size? Any abnormality in the vital size of this trial?
wow. I think the pulse is a bit high. 1070 per minute.
1070. Yeah,
100.
heart is a little bit high.
Yep.
100.
And the respiration too.
You have the okay, also the high respiration rate.
Yep.
About the blood pressure.
I think it's normal.
Yep. Okay. So anything else? Anything
Mm.
else about the clinical symptoms is abnormal?
The murmur.
The murmur,
The murmur. Yep.
laugh. We hear the continuous murmur. The continue is for persist continuous murmur along the upper left sternal border.
Yep.
Mhm. So we just analyze this case and we hear that this child have many abnormalities. Just not like the first case, okay? She have the history of premature and premature gestation, the history of poor feeding, and he decrease the amount of urine and increase the heart rate, increase the respiratory rate.
Mm-hmm.
Mhm. And also um, this infant also has the symptom of sweat a lot while feeding. Okay,
Mm-hmm.
it means that it means that
Exertional tired when exertion.
exertion.
Mm-hmm.
Exactly. So it means that this child can be have the proper reaction with the exertion.
Mm-hmm.
Mhm.
I'm sorry. This word is exertion. What does it mean?
Ex- Exertion means that when he have to do something that require more energy,
Mm-hmm.
he will not he will reveal the symptoms like increase the pulse, increase the the respiratory rate. Okay.
Mm-hmm. I mean, you work hard and you have to use a lot of energy and like consume more oxygen. We call
Mhm.
exercise.
Mhm.
Vietnamese.
So what do you think? What cause all of these symptoms? You know, when when I see in a patient with a high heart rate and high respiratory rate, I think about this patient have the first thing is about the distress, the respiratory distress. You know, the respiratory distress, and the second thing is something that's um, that in decrease the perfusion. You know, decrease the perfusion.
Yeah,
Perfusion.
yeah.
hmm That is the reason why this patient reveals all the symptoms of like decrease the urine, increase the heart rate, and increase the respiratory rate
Mm-hmm.
because he has a decreased perfusion, right? It means that there are some abnormality in his heart that make it can supply enough blood for all the activity of the body. So
Yeah.
it stimulates um, the system the what the hệ thần kinh giao cảm hệ thần kinh giao cảm á.
Uh,
Sympathetic.
Yeah, sympathetic.
yeah.
Um, so that's the reason why she had the sweat, the symptom of sweat, the
Mm-hmm.
symptom of yeah, increase all the vital signs like pulse and the respiratory rate.
Mm-hmm.
Mhm. So we also noticed that the patient have the continuous murmur. The continuous
Yes.
murmur. It means that it is some sums that never close here. Okay, the sun that never close and make the patient have the decreased perfusion.
Mm-hmm.
It means that the sun that decrease the blood flow to the systemic circulation.
Mm-hmm.
Mhm.
Mm-hmm.
So we also refer to the location of this sun in the upper left sternal border. Upper left sternal border. It is the location of what? Of where? It's the locations of the pulmonary. Yeah, pulmonary valve. The pulmonary valve. But but in here, maybe it's not the abnormality in the pulmonary valve because it is continuous murmur. Okay,
Mm-hmm.
it is
Yeah.
something that near the pulmonary valve and create the murmur.
Mm-hmm.
The aorta,
The aorta,
the COA, the coarctation of the aorta, I think.
Oh.
the coarctation of the aorta, we just referred before that the coarctation of the aorta will create the difference between um,
Um,
blood
the,
pressure from the upper side and the lower side of
yeah, yeah.
the body. And she also have the lower cyanosis. But in this patient, we didn't see this symptom.
All right.
Okay? We didn't see this symptoms. So we should
Oh,
think about another
mm,
another abnormality
yeah,
that it will um, that it will make the blood from the left to the right,
mm,
right, from the left to the right, and it creates the continuous murmur. So we just kind of open this slide, and we can, yeah, think about any defects.
oh, let me think.
Yeah, here we see this patient is in the category of acyanotic defect, right?
Yeah,
Because we didn't hear any symptoms of cyanotic in this patient, and we just analyzed that the patient didn't have um, didn't have any obstructions because we hear the continuous
murmur.
murmur.
Yes.
Continuous murmur. Sorry, we hear the continuous murmur. So that's the reason why we didn't have any um, abnormality with the valve because the valve can open and close with the heart rate.
This
So it's
will have
generally
a present in animal face, systolic or diastolic, but now it's not like
yeah,
always have the murmur.
yeah. That's the reason why it's not a VSD or ASD, right?
Mm-hmm.
Mhm. With the outflow obstruction, we can see the difference in the hypertension and the difference in the cyanotic symptoms between the upper side and the lower side. You understand?
Mm-hmm.
Yeah,
Mhm. But in this patient, we didn't see any difference between the upper and the lower.
mm,
So we will not refer to the aortic stenosis or coarctation aorta with the pulmonary side stenosis. Do you think that this patient have some abnormality with the pulmonary artery?
well, I don't.
Actually, it has
Yeah,
symptoms that it has its symptoms of pulmonary artery because this patient have the high risk of pulmonary distress. Okay.
Yep.
Yeah, and he also um have the more blood from the systemic circulations to the pulmonary circulations. So it's not the symptoms of pulmonary stenosis, because in the pulmonary stenosis it will make the blood to congest in the lower part, congest the lower part, and it will create the symptom of organ megaly, like hepatomegaly, and the
Yeah.
mhm. But we didn't see any symptoms of congestion, lower part congestion in this. The patient has the symptoms of pulmonary stenosis. We only we only have one defect that's suitable for all the symptoms. It is the what? The patent ductus arteriosus, right?
Mm-hmm.
Um, we just um, we just come back to our case here that this patient have the continuous murmur. It's very suitable for a shunt that never close, right?
Mm-hmm.
And the patent ductus arteriosus it will create a shunt from the systemic circulation to the pulmonary circulation. That's the reason why this patient reveals the symptom of decreased perfusion. And we also come back to the history of this patient. He have a history of premature gestation. It means that when he was born, there is some symptoms of um, lower oxygen,
Mm-hmm.
So it will create, it will stimulate the production of prostaglandin E2. Prostaglandin E2, it will make, it will stimulate the artery to be kind of be latent. It's latent, opposite to narrowing.
Um, so keep this open.
Yeah.
When keep this open.
It keep the arteriosus open. Keep it open.
Yeah. Yeah.
So
So. Mm-hmm. Yeah. Go ahead. Go ahead.
it makes this patient have the symptoms like decrease the perfusion and poor feeding and the murmur, continuous murmur, because the arteriosus, the ductus arteriosus is still open. Normally, it should be closed after 15 hours of birth. But because this patient lacks of oxygen uh, when he was born premature, so that's the reason why the ductus arteriosus is still open until 1 month old.
Mm-hmm.
So because it creates the symptoms of low perfusion. So this patient should receive some treatment or some intervention. Right
Mm-hmm.
now, in this checkup, in this time, we should not reassurance and let him come back home, because in the next time when he come back to us, he will reveal the more severe symptoms, even the symptom of heart failure. In the next time when he come back to us, if we do nothing for him, he will have the symptom of low development. It's not just simple like this. Now he's still normal with weight 3.5 kilograms, and the length is 52 centimeters. But the next time when we do nothing, in the next month, in the in the first month, he will you have the low development, the bad development. Okay, so we should not choose uh, the the option A. For the for the option B, we also should not choose the option B because we've just said that BCE2 or BCE1 will will make the artery to be opened, and which it will kind of it should have any usefulness in this situation, right?
So you not understand that one? Do you understand that?
Yeah. Uh, yeah.
Okay, so we just only have four options. So what do you think is the most appropriate answer for this question? In
Well,
option.
I think that the next step is endomycin infusion because I think that the X-ray of the chest is not very useful in this case because the diagnosis is confirmed, and moreover, the X-ray can do anything more to diagnose this case. So, and about the choice of digoxin and furosemide, I think that if we can solve the solve the PDS, I'm sorry if I didn't remember the name of the disease. I think that if we can close the close it, the signs and the symptoms of this patient can improve. So,
Mhm.
and about the surgery, I think it's not necessary at this time. So I think is the correct answer.
Uh,
E is correct answer. Yeah, exactly. So you think very good that this patient need to do something to close the ductus
Yeah.
arteriosus. Okay? So we have only two options is C and E to the, the close the bridge, right? And for the C, the percutaneous surgery. You know, it's not used in this patient, but with the some kind of some other children who is full term pregnant, full term gestations, and who is greater than 5 kilograms, they will not use the endomethacin infusions to close the percutaneous surgery because in the full term it can't be close the ductus with just only the endomethacin because she or he is not lack of endomethacin. So that's the reason why we can't use it to treat for the patient. We just use the endomethacin infusion for some preterm children. And
mm-hmm,
yep, so endomethacin infusion is the most appropriate next step in this patient.
mm-hmm,
But if we did this step, do you think that we should do any other next step? I mean that after endomethacin infusions, should we do anything else for this patient?
mm-hmm.
Should we do the chest X-ray?
Do the chest X-ray after endomycin infusion? You mean that?
You mean that?
I mean that this with this tries did he need any any other other tests like other imaging tests or
Echo,
other kind of
echo,
laboratory to yeah
do
to
echo.
diagnose to give the definitive diagnosis and for the treatment of the patent ductal arteriosis.
I think we can do echocardiography for him.
Yeah,
And also,
echocardiography. Mhm. For most of the congenital heart defects, the echocardiography is the definitive diagnosis, and we should refer the patient to the hospital where we can we can use the echocardiography for the patient.
mhm.
Yeah, yeah. I just want to remind you that echocardiography is very important for the for detect the congenital heart defects in infants.
Mhm.
So yeah, so the answer for this case is E, right?
Mhm.
Yes.
Do you have any other suggestions or any question for two case today?
Well, as I read in some source, it said that I'm sorry, the doctors can be closed spontaneously.
Mm-hmm.
Um, yeah, from 6 to 11 weeks
Six to
after
11.
after yeah after the children be born.
Mm-hmm.
After the children born. Yes.
Was
So I'm a bit confused about that. If it is true, if this can close spontaneously, 6 to 11 weeks after born. So
mm-hmm.
if it's true, we can reassurance in this
Mm-hmm.
case, right?
Um, Actually, we can reassure and follow up for the patient who have very kind of latent symptoms or have no symptoms.
Mm-hmm.
But this patient have some kind of severe symptom, and if if we just follow up and do nothing for him, the symptom will be more severe
All
and
right.
affect for the development of the patient, of the infant. So that's the reason why we should do the medical treatment in this time, not wait anymore.
Yeah, I got it.
So do you have any other
No,
question?
thank you.
Mhm.
No. Yeah.
Oh my gosh, it's 1.5 hour.
Really? Oh wow.
So yeah. So I still do have anything to share with us about
I
acyanosis
think this
and
case, yes, this case would do very good
Yeah, that's
and
one.
explain everything about this. Just like just summarize for the endomethacin, this is the NSAID, right? The NSAID we act on the inhibit COX cyclogenase and decrease the prostaglandin level, and this stimulate close the hole the detector the ductus close, and this only effect on the premature infants when the if it's not like for some people, for some infant their weight more than 5 kilogram, and this not have effect,
mm-hmm,
so it's just premature and very low weight.
mm-hmm,
Otherwise we have to do surgery,
mm-hmm,
for that.
yeah,
That's just that. Just I just want to summarize for easy to remember.
mm-hmm.
And
Oh,
and well done, when you do very great job about 2K today. And I think you're a good teacher to can help the student understand wow every point here. More than like just like we try to figure out where's the answer, but
mm-hmm,
we need to understand about all of the things for explanation. So
mm-hmm.
that's good. That's good.
Yeah, I just try
Yeah.
my best, but I
Yes, it's just next time we can, if we can reduce a little bit about the time frame. Make sure like in 1 hour. That's good. That's better. Yeah, just that.
I think that's only you guys feel a bit of tired because you have to, yeah, you have to stay in front of the screen for too long.
Actually, like just for the because like I feel I understand why you have to try to explain for that because like you want to make sure the audience can understand well all of the concept here, and
Mm,
that's good. We if we have more time, that's really good. But sometimes when we don't have much time, we have to reduce that. That's depend on the talk and the situation. So don't worry about this.
yeah, thank you so much.
And I still plus more slide below that.
Yeah.
You can take a look at this for understand about anatomy of the those of the defect here, and that's for the fetal circulation or postnatal circulation. Something changed. So just compare this, and you see what changed. Totally a lot of things change compared with the like the infant and the adult, right? Natal. Yeah. The next picture, the next picture about the what we call this side clapping, clapping, digital clapping, right?
Yep.
Yeah, that's for the some the mechanism. Do you who know what kind of mechanism of this?
Because it is the decrease perfusion to uh, to the peripheral side of the body.
Decrease
There
what?
is decrease the perfusion, the
Perfusion. So
oxygen.
yes, because of the condition is a hypoxia. Hypoxemia and hypoxia too.
Yeah.
So that's make decrease of blood perfusion or oxygen to the extremities, especially in the finger. And it's a long term. It need long term to have this picture. So that's the popular picture for any case patient who have decreased oxygen. We call hypoxemia.
Yeah.
Okay. hmm Yeah. And what else? They also happen with COPD or uh, have polycythemia.
Yeah. So because
Mhm.
it decreases the oxygen to this side, so it will stimulate the production of fiber, the fiber.
Mm.
That's the reason why we see it have the kind of a bigger size than normal.
Yep. Yeah. Correct. Correct. The next picture. You have me to see this picture. Okay, this is a picture for what? Who know?
Um, Alzheimer's syndrome.
Dementia syndrome. Well, let's see.
At the first time, um, the ventricular defects will create
Yes. First of all, this is
the sun
VSD,
from
right?
the sun from the right the left to the right,
Mm-hmm.
and the patient have no cyanotic symptom at all.
Mm-hmm.
But when the tension in the right side of the heart increase, it
Mm-hmm.
will change the direction of the sun from the right to the left.
Yeah.
So
As
that
I mentioned.
yeah,
Yeah, as I mentioned.
will
Syndrome,
the
yeah.
symptoms.
Changing about the shunt from the left to the right to the right to the left. And this
Yeah,
case patient had a VSD. Just that.
yeah.
Next
We call it Extend syndrome.
syndrome. Just stand. You can write down for have.
Extend
Mm.
um,
How do you know that word?
Extend Yeah.
Yeah.
Mm-hmm.
And
Yeah. That's it. Mm-hmm. No problem.
see that? Yes, asymmetrical syndrome. Yeah.
You see that? I can't find any. Oh yeah. Yeah. But the first time is from the left to the right, and then will the pulmonary hypertension is higher than the left ventricle. It will change the direction from the right to the left. Okay.
Mm-hmm.
Mm-hmm.
And the next slide, please. Can you help me to show the next slide? Share new screen and show this. I want
Okay.
to just try to complete that. Yes.
Yeah.
Next slide, please. Next. This picture, the execution we will see with the patient who have the ASD, we call like heart murmur with individual septal defect, and what we call for that, this holocystic murmur.
Mm-hmm.
Holocystic murmur, just that means the whole systolic phase.
Mm-hmm.
Yeah.
Next, please. And that this case for the pictures is the wow, abnormal
It's actually the
ASD.
yeah.
This ASD case. Oh my God, there's a lot of things around me.
PDA.
Uh,
It's
this is
the
this is
patent ductal arteriosus.
PDA. Sorry, this is a this
Yeah.
is PDA. Yep.
Yeah.
Sorry, one
Yeah.
second. I have.
Yeah. At the first time, the blood flow from the left to the right like this, and then when the tension and the right temple is increased, and it will kind of change the direction, right, like this. You see it?
Yeah.
Mm-hmm.
When can you help me to keep continue? I will have delivery something and I just check it and I will back just 2 minutes. Okay.
Mm-hmm.
Thank you. Just finish that.
Ah, so so when
Yes.
um what grade are you in?
Oh, I'm in fifth grade, the fifth year. Yeah.
Fifth year.
Or
What? You are fifth year.
yeah.
So what department are you kind of rotate? Clinical rotation?
Well, I actually I didn't think about that. I haven't thought about that. Yeah. I think that if I can approach all the department, all the major, I can have a better selection. How about you?
Actually, I'm not sure, but
Yeah.
maybe I will become a physician.
Oh, what?
Not
Actually,
yeah,
what?
I mean that I will do in the hospital as clinicians.
Clinician, yeah.
Mhm.
Mm.
But
Uh,
mhm.
yeah.
Maybe it may be the pediatrician.
Wow.
Yeah,
Yeah.
or yeah.
I think that you would be suitable for some major like medicine, internal medicine, or pediatry. Yeah. Some kind, not the. I just think that just it's my impression about you because I haven't met you outside out of the internet, so I just think that it must be matched to you.
Internal medicine.
Yeah, or
You
or
think that I match with internal medicine?
or pediatry. Yeah, something not
Yeah,
involved
so much.
in surgery, something, yeah, something like that, not involving surgery
Yeah,
or,
thank
yeah, yeah.
you.
I think that you have to prepare so much for this case talk, and I appreciate that. Thank you so much.
Yeah, thank you.
Yeah,
I hope that you can understand everything that I try to deliver in this talk today.
yeah, yes, I got it.
Yeah.
In the first case, firstly, I think about the actual the actual the actual defect, but I
Mhm,
don't know why. I don't know why I eliminate this
mhm,
choice. Yes.
mhm. So,
Mm-hmm.
maybe in at the first, I just worry that you are still in you may be in the third year or just in the second year. You now
Really?
have. So I just try to explain in the way that the person who never know anything about the congenital heart defect, so
Mm-hmm.
he or she can understand what I said. So that's the reason why I try to explain very very details about the case,
Yeah, yeah, I
and
know.
I just try to explain the thing that it can analyze it. We can analyze from the the A point to the B point instead
Yeah,
of
yeah,
we have to be thoroughly about this that you can understand it.
yeah, I know.
Mhm.
I get it. Um, mm,
So I hope that you enjoy it.
yes, of course. I'm kind of people who forget easily. After exam, I totally forget everything,
Mhm,
and I need to review many times
mhm,
to remember one thing. Yeah. So before the case talk, every case talk, I have to have look at many things, many aspects. Yeah.
mhm.
Yeah.
Sorry. Yes. Keep going.
Yeah. Uh, you want me to stop here?
Yes. So this picture for
I think it's a continuous murmur, right?
this is for PDA. We call like continuous systolic and diastolic murmur.
Yeah.
Mhm,
And some document they will call like machine murmur, machine like murmur. That's typical
Mm,
murmur for PDA patient.
mhm.
Okay. So
I think that this picture about the difference in the upper and the lower side, different in the blood pressure of the upper and the lower of um, co at coartation of aorta.
Yeah.
I forget the first the first word. Coartation, yeah, coartation of the aorta.
Yeah. Quotation.
yeah.
So the positions of the coarctations will will decide the symptoms. And in the clinical situations, we should we should check for the blood pressure from the right arm and
Mhm.
the right arm and the right
And the
leg.
right leg.
Yeah,
Yes.
so that we will not kind of forget the symptoms of the coarctation aortic when it is in the situation second, like here.
Mm-hmm. Mm-hmm.
Mhm. So
Finish.
ah,
Yes. Finally, you finish. Yes, all of the below slide just help you to have the overview about the acynotic congenital heart defect because like we just for the question we just pay attention to case one is ASD and another case a PDA. That's it. So we still have another defect belong to acynotic group. So just for overview for that. And if you want to learn more, just read about this. And we work really hard today, right? Oh, let's see.